Hi guys, today a quick video where we'll go over the basics of radiotherapy in breast cancer. But before we start, I just wanted to say a big thank you. We are already 36 on the channel, which is awesome. Thanks to everyone who likes, who comments, it really helps. And if you are interested in radiation oncology, don't forget to subscribe so you don't miss the next videos. Alright, let's jump into breast cancer, starting with a few words about epidemiology. Breast cancer is the second most common cancer worldwide, just right after the lung cancer. Every year, there are about 2.3 million new cases in the world and around 670,000 deaths caused by breast cancer. Let's start with the main non-modifiable risk factors. They are the ones we can't really change: sex and age, a personal history of invasive or non-invasive breast lesions, and of course genetics, including family history and mutations like BRCA1 or BRCA2. Now, on the other hand, we have the modifiable risk factors, which are mostly related to lifestyle, hormonal exposure, things like weight, lifestyle habits, for example, alcohol consumption, radiation exposure, hormonal factors such as early menarche, late menopause, or exogenous hormone therapy. Interestingly, pregnancy also has a protective effect. Breast cancer screening is recommended for women aged 50 to 69 years old, but sometimes a woman can feel a lump herself during self-examination, or there could be other clinical signs that raise suspicion. In this case, we perform a mammography and an ultrasound. If the radiologist assigns a score by rates of 4 or 5, meaning there is a suspicion of cancer, the next step is a biopsy to confirm the diagnosis. Here is an example of a pathology report you might receive after a biopsy. This one shows an invasive ductal carcinoma, no special type, also known as NST. It's a grade 2 tumor, meaning it has moderate differentiation. We also see the main biological markers: estrogen receptors, progesterone receptors, Ki67, and HER2 negative in this case. These four markers, ER, Ki67, HER2, are used to evaluate the tumor and to classify it into the main biological subtypes: luminal A, luminal B, HER2 positive, triple negative breast cancer. Each of these subtypes has a different prognosis and requires a specific treatment strategy. In this case, we are dealing with a luminal B breast cancer because the ER and the PR are positive, so the hormone receptor are positive, and the Ki67 is more than 14. Once we know it's a breast cancer, we need to check the rest of the body to make sure there are no distant lesions. That's why we perform a staging workup, which currently includes a chest and abdominal CT scan and a bone scan. Sometimes a PET-CT with FDG can also be used depending on the clinical context. The treatment of breast cancer usually follows this sequence: surgery first, then radiotherapy, and finally endocrine therapy, which is continued for 5 to 10 years. In some cases, in many cases, chemotherapy can be given before surgery to shrink or downstage the tumor, or after surgery, especially for the high-risk cancers. But remember, every breast cancer is different, and the treatment plan, whether it's surgery, chemotherapy, immunotherapy, radiotherapy, or hormonal therapy, depends on the molecular subtype and the size of the lesion. In most cases, if the size of the tumor and the breast allow it, we perform a lumpectomy combined with a sentinel lymph node biopsy. Traditionally, If the sentinel node were positive, an axillary lymph node dissection, or ALND, was performed. ALND means removing all the lymph nodes in the level 1 axilla. This procedure was effective but often caused lymphedema. That's one of the reasons why axillary radiotherapy is now preferred in many cases. It's less invasive and helps reduce side effects. But it's not recommended if the lymph nodes are still positive after chemotherapy given before surgery. The goal of radiotherapy after surgery is to eliminate any microscopic disease that might remain in the breast after lumpectomy. In other words, radiotherapy acts as a local treatment that replaces mastectomy. It allows us to conserve the breast while still achieving excellent local control. Radiotherapy is therefore systematically indicated after a lumpectomy. After a mastectomy, it's indicated in cases of large tumors such as T3 or T4, or when one or more lymph nodes are positive. Historically, radiotherapy for microscopic disease was delivered with 50 gray in 25 fractions over 5 weeks. Then the START B trial showed that a shorter schedule, 40 gray in 15 fractions over 3 weeks, was just as effective and safe. More recently, the Fast Forward trial demonstrated that in an even shorter regimen, 26 gray in 5 fractions over 1 week, is comparable to the 3-week schedule. However, the 10 years results are still awaited, especially for the lymph node irradiation and the tumor bed boost. The boost is an extra dose delivered to the tumor bed area, especially in younger patients or those with high-risk features. In this case, we deliver 40 gray to the whole breast in 15 fractions and 48 gray to the tumor bed in 15 fractions too. In cases where a lymph node is involved, we irradiate the red regions on the diagram. That includes the level 1, the level 2, the Rotter's nodes, level 3, and level 4. If an axillary lymph node dissection has already been performed, level 1 can usually be spared. And in some cases, the internal mammary chain may also be included. Toxicity in breast cancer, in breast radiotherapy, is directly related to anatomy. Because the breast is close to the lung, there is a small risk of radiation pneumonitis. We can also see skin toxicity, especially in skin folds, and cardiac toxicity, which can be reduced thanks to modern techniques like the IBH, prone breast irradiation, IMRT, protons. There's also a small risk of secondary cancer, mainly in the contralateral breast, or it can also be into the lungs, and fibrosis, especially into the boost area. Finally, lymphedema can occur, but it's much less frequent than after a full axillary lymph node dissection. Thank you for watching. Don't forget to like and subscribe, and see you in the next video. Bye.